بسم الله الرحمن الرحيم. السلام عليكم. أنا محمد حسنين، استشاري غدة صماء في دبي وفي جامعة كارديف ورئيس دار International Alliance. A great pleasure for me to introduce Professor Ines Shaltut. I don't think when this webinar is for Egypt, Professor Shaltut needs any introduction. Most probably even the policeman in the street knows Professor Shaltut, one of the eminent professors in diabetes and in medicine. Today, the webinar is covering topics related to the Ramadan. There will be two parts. Professor Ines Shaltut will cover the management in the context of COVID-19, and then I will share with you some of the important data on very recent study just been published last night, actually, on sulfonylurea in Ramadan, the diamicron study. Professor Ines, the floor is yours.
أهلا وسهلا بحضراتكم. طبعا بشكر دكتور محمد على المقدمة اللطيفة. دكتور محمد also is a very eminent speaker worldwide has a very good experience in a very hot topic these days, diabetes and Ramadan. I'm going to talk about type 2 diabetes management in Ramadan in the context of COVID-19. The global impact of COVID-19 has been profound. It is the most serious respiratory virus pandemic since the 1918 H1N1 influenza pandemic. أخطر pandemic حصلت بعد يعني حوالي قرن كامل من ال H1N1 influenza pandemic هو ال COVID-19 اللي احنا فيه. ليه؟ COVID-19 has now 2.6 million cases worldwide and 183,000 deaths confirmed worldwide. All countries are reporting cases. This data is today, April 23rd, and the mortality rate now is 7%. The mortality rate is increasing. COVID-19 is a new strain of coronavirus. It's a family of wide range of different strains, including that causing common cold. وكلنا أخذنا خلاص فكرة وقرينا كتير على ال COVID-19. What about COVID-19 and chronic disease? The magnitude of outcomes. And let me start with the Chinese experience. According to the Chinese Center Disease Control, the overall mortality in China is 2.3%, and mortality rate in hypertensive patients was 7.3%. Sorry, in hypertension it is 6%, in diabetes it is 7.3%, in those above the age of 80, 10.5%, and cardiovascular disease also it jumped, and in patients with cardiovascular disease the mortality rate is greater than those with chronic respiratory disease. 3 studies were published in the Lancet, and one of them showed the comorbidity of 32 non-survivors. This is from a group of 52 intensive care unit patients, and those patients, 22% were having cerebrovascular disease and 22% were having diabetes. The second study among more than 1,000 patients with confirmed COVID-19, 173 cases had severe disease. Those with hypertension were 23%, diabetes 16%, coronary heart disease 5.8%, and cerebrovascular disease 2.3%. Another study, 140 patients were admitted to hospital, 30% had hypertension and 12% had diabetes. These are the most frequent comorbidities reported in patients with COVID-19 in different trials. COVID-19 is linked to renin-angiotensin-aldosterone system, and the expression of ACE2 in patients with type 1 and type 2 diabetes is increased. And what is the diabetes and COVID-19? Is there any association? In Chinese Center of Disease Control and the Chinese Society of Diabetes, they said that people with diabetes have increased risk to infection because of immunity defects. Immunity defects is linked to hyperglycemia. Both acute and chronic hypoglycemia may lead to immunity defect. And there is increased risk of severe infection due to increased cytokines. So in Chinese survey, 10% of coronavirus patients are diabetics. These are the clinical scenarios of diabetes management with COVID-19 in China experience. Diabetes mortality was 7.3%. All patients' mortality was 2.3%. No comorbid conditions mortality 0.9%. There was fear and anxiety and tension, which may increase glucose levels and causing fluctuations. Maybe interruption of oral antidiabetic medications with isolation, and COVID-19 caused increased inflammatory cytokines, and also in cases using glucocorticoids in treatment, there was sharp increase in hyperglycemia. Some patients were having a regular diet, reduced exercise, gastrointestinal symptoms, and those also caused glucose fluctuations. The recommendations of management by the Chinese Diabetes Society for mild and moderate cases, non-elderly COVID-19 patient, strict control of blood glucose. For mild and moderate elderly patients or with glucocorticoid medium control targets. And for severe critically ill patients, elderly patients, hypoglycemic or comorbidities or organ dysfunction, low glycemic targets, where they allowed the postprandial blood glucose to reach from 180 to 220 milligram per deciliter. And again, the Chinese Diabetes Association, for the treatment of severe infection, insulin was the first line of treatment. And for stable cases, regular eating pattern, patients can keep on oral treatment. And to avoid metformin in GIT disturbance or low oxygenation, and they didn't recommend DPP-4 inhibitors or SGLT2 inhibitors. And this was done for different types of patients. Type 1 patients, they recommended insulin pump or basal bolus insulin. For type 2 diabetes with low or moderate glucose increase, non-insulin drugs can be used. For patients with fever or glucocorticoids treatment, insulin is the first line of choice. And for glucocorticoid-associated diabetes, insulin is the first choice. Coming now to Italy, and these data were based up to 17th of March, and those were the fatalities. The mean age of fatalities was around 90 years, and the majority were males. Almost 50% of the patient had at least 3 or more comorbidities. In less than 1% of patients, fatality, no comorbidities were documented. And hypertension was found in 76%, and diabetes was found in 36% of fatalities. Now we come to the American Diabetes Association, and there's different recommendations or views and Chinese experience. And the American Diabetes Association asked this question: how coronavirus impact people with diabetes? Are people with diabetes more likely to get COVID-19? And ADA said no, people with diabetes are not more likely to get COVID-19 than the general population, and the problem that it is a problem of worse outcome, not greater chance of contracting the virus. Again, the American Diabetes Association, this was the second topic. Do people with diabetes have higher chance of experiencing serious complications from COVID-19? Yes, people with diabetes do face a higher chance of experiencing serious complications from COVID-19. Diabetic patients are more likely to experience severe symptoms and complications when infected with a virus. But if diabetes is well managed, the risk of getting severely sick from COVID-19 is about the same as general population. يبقى ده الاختلاف اللي احنا شايفينه ان التشاينيز بيقولوا ان diabetics are more prone to COVID-19 infection and more prone to severe infection and fatality, لكن الامريكان Diabetes Association بتقول no increase in chance of infection for diabetics, but infection is severe in cases of diabetes. The third topic of the American Diabetes Association, are the risks different for people with type 1 or type 2? No, we don't know any reason why COVID-19 is different in type 1 or type 2. The most important is the association with comorbidities. Those who are having comorbidities are more prone to serious disease. This was the recommendation of AGA and Diabetes UK for people with diabetes. Population living with compromised immune system need to take special care. Infection raises the blood glucose. How should people with diabetes and their families prepare themselves? This was the advice of the AGA and Diabetes UK. General recommendations apply, like frequent hand washing, sanitation of devices, phones, laptops, minimize unnecessary going out, travel or gathering, and to prepare for sick days measures. SMBG more frequently, make sure of supplies like medications, vitamins, rubbing alcohol soap, supplies of glucose test strip and ketone strip, which should be used when the blood glucose is above 240. And when to contact your doctor. Contact your doctor for diabetes medications, for cold, flu, or infection, for management of urine ketone if prepared, and for advice about the requirement of medication change if any symptom of COVID-19 happens. Coming now to practical advice of DAR, Diabetes and Ramadan Alliance, and the first advice is to stay at home. Extra attention to good glycemic control is required to avoid overeating while staying at home. Healthy life options is required, and to regularly monitor the blood glucose and also the ketone checks if the blood glucose is high, and to know that infection can cause hyperglycemia and dehydration, so we should supply ourselves with water or unsweetened drinks. Regular physical exercise and daily exercise at home, because diabetics need to stay at home. Again, Ramadan fasting, according to DAR Alliance IGF recommendation, and this is a question, in general, is it safe for a person with diabetes to fast Ramadan or not? Most diabetic patients can fast safely, especially those controlled patients or on safe medications, but this depends on the risk of the individual assessed by their physician. We're going to talk about risk assessment, And the risk of fasting is low if the patient is having controlled type 2 diabetes or treated with tablets or GLP-1 receptor agonist injection or once daily basal insulin. Other people are considered high or very high risk of fasting Ramadan. The second question, with regards to COVID-19, which person with diabetes is at extra risk of fasting? If the blood glucose is high, most of the time, if the person has diabetes-related complication like heart or kidney disease or foot infection, the condition may be worsening with the chance of getting infection with COVID-19. Then, patients with persistent high blood glucose, patients with recent diabetes ketoacidosis, or very high blood glucose, patients with other medication or other medical condition like heart disease, kidney disease, or foot infection, and elderly patients with diabetes or generally poor health, and those with acute illness, those persons should be stressed not to fast, to avoid fasting. These are practical advice during Ramadan: stay at home, follow the general advice of COVID-19, extra attention to lifestyle, to regular blood glucose monitoring, to drink plenty of water, to check the acetone level if the blood glucose is high, and how to manage type 2 diabetes. These are examples to lifestyle and how to take iftar meal and sahur meal, how to take dessert or some non-sugary or low sugar juices or drinks. And those are factors to assess risk in diabetic patients. What is the type of diabetes, individual hypoglycemic risk, social work circumstances, patient medication, the presence of complication or comorbidity, and the previous Ramadan experience. And we're having very high risk group, like we said, and high risk group and moderate or low risk group. And these groups are, like we said, in the very high risk group, and the high risk group are patients with complications on the cardiovascular disease, foot infection or diabetic foot, poorly controlled patients, poorly controlled type 1 diabetes, pregnant ladies, elderly patients, those who were having hypoglycemic coma or ketoacidosis, or recurrent hypoglycemia 3 months before Ramadan. And the presence of COVID-19 epidemic is serious for those patients, and they should take the advice not to fast. The category 3, patients with lifestyle or metformin, acarbose, isoleucidine, second generation sulfonylurea, incretin-based therapy, SGLT2 inhibitors, or basal insulin, they can fast easily with the advice of their doctors. And when we are talking about the oral anti-diabetic medications, metformin, there is no need to change the dose. And if the patient is taken once daily dose, then with iftar, 2 daily dose with iftar and sahur, 3 daily doses, 2/3 of the dose with iftar and 1/3 with sahur. And for prolonged release metformin, the dose should be taken with iftar. For sulfonylurea, for once daily dosing to be taken at iftar, and if there is tight glycemic control, we can think of reduction of the dose. And for older classes of sulfonylurea, like glipenclamide, it's not safe to use during Ramadan, and the second generation sulfonylurea are more safe. Glitazones, no dose change is recommended, and DPP-4 inhibitors, no dose change is recommended. And now we are coming to the end with IGF DAR practical guidelines. The religious opinion from Mufti of Egypt. رأي دار الإفتاء في حكم الصيام لمرضى السكر الصوم فريضة من فرائض الإسلام أناطها الله تعالى بالاستطاعة. فإذا لم يستطع المسلم الصوم بالامتناع عن المفطرات من الطعام أو الشراب ونحوهما من الفجر إلى المغرب فإن له رخصة الإفطار. بل إن كان الصوم يضر بصحته بقول الأطباء المتخصصين فيجب عليه أن يفطر حفاظا على صحته. دي الإفتاء مخصوص especially to DAR Alliance Diabetes and Ramadan Alliance. هختم بفتوى أخرى، فتوى قدمت لنا الجمعية العربية لدراسة أمراض السكر والميتابوليزم، والفتوى من إدارة الإفتاء بدار الإفتاء، الفتوى المكتوبة، وجزء منها هقوله لحضراتكم مهم جدا. فإن غلب على ظن المريض له إن صام حصلت له مشقة أو صام ثم حصلت له المشقة سواء باشتداد وطأة المرض عليه أم احتاج إلى تناول الدواء أم غلبه الجوع أو العطش، وهذا هو حال غالب مرضى السكر، جاز له أن يفطر، بل ويجب عليه أن يفطر إذا خشي على نفسه من الهلاك، لقول الله تعالى ولا تقتلوا أنفسكم إن الله كان بكم رحيما، سورة النساء. وقوله تعالى ولا تلقوا بأيديكم إلى التهلكة، سورة البقرة. فالحقيقة الفتوى واضحة جدا، وإحنا يعني نرجو لحضراتكم أن توصلوا المعلومة بالنسبة للهاي ريسك patients your high risk patients. شكرا لحضراتكم، رمضان كريم، تقبل الله منا ومنكم صالح الأعمال. شكرا لكم.
Thank you very much, Dr. Ines, for the very clear presentation covering the COVID disease and diabetes, as well as the fasting, and indeed covering very important sections of the management of diabetes during the month of Ramadan. Please write your questions on the chat platform, and we will discuss all the questions at the end of both presentations. We now just change slides and change platforms for me to upload my slides. Just hold with us for a minute or so. أبدأ. Okay, Bismillah ar-Rahman ar-Rahim. So now we move to the next part of the presentation, which is related to the sulfonylurea in Ramadan and beyond. And we'll focus on the Ramadan study, which has just been published. So as you all know, that from the first recommendations that we did among a large group from the Middle East and some of the eminent professors in Egypt in 2005 in collaboration with the ADA, it was stressed upon that the sulfonylurea as a class are potentially with higher rates of hypoglycemia. And it was also mentioned during these recommendations that different sulfonylureas have different risk of hypoglycemia. So it's important for us to try and understand. The question really is, could we put all sulfonylureas in the same basket? Do they all have the same risk for hypoglycemia when it comes specifically to the fasting of the month of Ramadan? Here I will share with you some of the important studies that were done in the field of sulfonylurea in some of these studies in comparison with the DP4 inhibitor. 4 of these studies have looked into the rates of hypoglycemia, and as you can see, glibenclamide in all of these studies comes to be the highest risk of hypoglycemia, and the least in them would be gliclazide. Now, when we wrote the latest recommendations with the IDF in 2016, we looked again into all of these studies, and it was clear to us to state that glibenclamide should be avoided if possible. I understand, of course, that many people like to prescribe leveneclamide because it's the least expensive, and also because it's a powerful sulfonylurea. But this is important to try and differentiate between the different risks of hypoglycemia when it comes to Ramadan. I will share with you now some of the recent data. The Darmina study we published last year, this is a study from 10 different countries in the Middle East and North Africa region, and it included almost 1,900 persons. And in gray is the rate of hypoglycemia during Ramadan, and in black is the rate of hypoglycemia out of Ramadan. And as you can see for oral therapy, out of Ramadan, there is very little difference between hypoglycemia, whether a person is on sulfonylurea or not on sulfonylurea. Why? Because actually we are eating or snacking most of the time. But when it comes to the month of Ramadan in gray, you see that the rates of hypoglycemia increase from 4.3 without sulfonylurea to 9.2 with sulfonylurea. And it's important to remember that in this particular study, actually leveneclamide was the least of the drugs used. It was only 6%, 5.8 to be precise. Glimepiride was the highest, followed by gliclazide or gliclazide MR. The study did not differentiate to us which one of them caused the highest rate of hypoglycemia as a subgroup analysis. We did not have this. Now, this is another study that I had the pleasure to co-author with my very good colleague, Professor Ibtisam Baisa from Dammam in Saudi Arabia. And in this particular study, they looked into their center and they looked into 200 persons taking oral therapy. 119 of them were on sulfonylurea, which in the center is gliclazide or leveneclamide, and the rates of hypoglycemia there was 20%. For those on oral therapy without sulfonylurea, the rates of hypoglycemia was 5%. So clearly, sulfonylurea as a group could be of a higher rate of hypoglycemia for many people with diabetes. Now, this is one important point in the study as well. The vast majority of the hypoglycemia occurred during the fasting hours, 92%. So it's important that we address this. The second thing is, while the rate of hypoglycemia is high, 99% of it is minor hypoglycemia. By minor hypoglycemia, I mean a type of hypoglycemia that the person himself or herself will be able to detect and stop confirm, of course, by checking and then stop. Stopping was not always done, as you can see from the line below, that 29% did not stop the fast when they were hypoglycemic. I assume that these were hypoglycemic episodes very close to the time of iftar, and the person has not long duration of diabetes. They had good adrenaline and good glucagon and good cortisol response, and they were able to get out of the hypoglycemia. This is a bad practice and should not be advocated at all by any person during the month of Ramadan when they are fasting. But I will share with you now the latest study on diabetes and Ramadan regarding the gliclazide MR. In fact, we have the notification for the study being accepted only 48 hours ago, and as you can see, that the acceptance officially in the journal was the 10th of April, and it just took 2 weeks for all the internal approvals. So I'm delighted to share with you some of this data for the first time. The design of the study is very straightforward. We looked into people with type 2 diabetes who were aged over 18 years, who were on suboptimal control. By this, we meant that their HbA1c is 9 or below. They had to be all treated with gliclazide MR, and they needed to be not on insulin. They also needed to be on the drug for a minimum of 90 days. Of course, as we are looking into Ramadan, we want people to be checking their SMBG on a regular basis, and we cannot do a Ramadan study without a person being fasting Ramadan. The exclusion was only for insulin therapy. All other therapy was not excluded. Why we excluded insulin? Because obviously the availability of insulin would make the potential of hypoglycemia higher, and it will make it different for us to differentiate which is which for the cause of hypoglycemia. Plus all the usual exclusion criteria in any studies, liver disease or renal impairment, and so forth. The study was very simple, only 2 visits. 1 visit before Ramadan, 6 to 8 weeks before Ramadan, and then the Ramadan period, and the following visit was 4 to 6 weeks after Ramadan. I'm delighted to share with you the results. 1,214 persons from 9 different countries took part in the study. Almost 52% from Asia Pacific region and 47% from the Middle East and North Africa region, including 16% from our beloved country, Egypt. The primary endpoint was the proportion of patients with at least 1 symptomatic hypoglycemic event. The secondary endpoints, we wanted to look into efficacy as well as hypoglycemia. Why is it important to look into efficacy? Because many patients and many healthcare professionals are just focusing on hypoglycemia. They reduce the therapy too much, and the person ends up with little hypoglycemia, but with a serious hyperglycemia. We want Ramadan to be a safe month for both hypo and hyperglycemia. So part of the secondary endpoints were the parameters for glycemic control and weight, as well as proportions of patients with 1 or more confirmed hypoglycemic event. Here we're talking about the hypoglycemic confirmed event, and with throughout the duration of the study, any hypoglycemic events. As you would expect, people had an average age of 54. Their duration of diabetes was 5.4 years. They were relatively well controlled with an HbA1c of 7.5% and a fasting plasma glucose of 140. The mean dose of gliclazide MR in the study was 74 milligrams, which is not a small dose. Many people had risk factors, but those with established cardiovascular disease were only 6%. 40% of the patients were on gliclazide MR on its own, and another 30% was gliclazide MR with 1 added drug, and then the last 30% were with gliclazide MR with 2 minimum added drugs. And I would like to share here with you some of the crucial data which is related to the hypoglycemia. First, we look into those with at least 1 hypoglycemic event of any type, and that was 2.3%. The confirmed hypoglycemic events were 1.6%. But I would like you to see the, I would like you to see the middle table, the middle row rather, which is the severe hypoglycemia, 0%. Not a single person in the study before Ramadan or during Ramadan or after Ramadan had a severe hypoglycemic event, which give us significant confidence for the use of gliclazide MR during the month of Ramadan. But I would like you also to focus on the data of pre-Ramadan and post-Ramadan. On everyday life, what is the rate of hypoglycemia for gliclazide MR during the month of Sha'ban or the month of Shawwal? 0.2%, which is indeed very low, and even lower for the month of Shawwal post-Ramadan by 4 weeks. So if we look into those who developed the confirmed hypoglycemia, there were 19 persons who developed the confirmed hypoglycemia, and many of them were those who are on triple therapy or more. So that obviously reflects not necessarily on the potency of the different drugs, but potentially maybe that the person requiring triple therapy or more could be vulnerable and have a higher rates of hypoglycemia. What about glycemic control? So I've showing you here the key messages. Symptomatic hypoglycemia 2.2%, confirmed hypoglycemia 1.6%, HbA1c although the HbA1c at baseline, and although the persons were fasting, it reduced by 0.3%. Fasting plasma glucose reduced from 140 to 130, a reduction of nearly 10 milligrams per dl. And weight, although the people in Ramadan, many of them overeat, but the weight in the study was reduced by ½ kilogram. And I remind you all that all this happened with no incidence of severe hypoglycemia. But I would like to look a bit more deeper into some of those who are more at risk for the hypoglycemia. I don't think age was a serious factor. As you can see here, the distribution of hypoglycemia below 50, above 50 or above 65 was not very high. But those with HbA1c less than 7.5, 12 of them had hypoglycemia out of the 19 persons who had the total number of persons with hypoglycemia. So far, we are getting a bit more clearer picture of who are these who are having hypoglycemia. One, the majority of them are on multiple therapy. Second, the majority of them are with good control or tight control. And the last important point, as you can see here, is the average number of meals. As you can see here, as I'm pointing the cursor, out of the 19 persons, 18 of them had 2 meals or less. So they are probably having iftar and maybe suhoor and maybe not. So clearly in my mind, if I'm a person taking sulfonylurea, I'm tightly controlled, I'm on multiple therapy, I need my suhoor as well, because 18 out of the 19 persons were having small number of meals, 2 or less. And obviously it's important for people to have enough meals during the month of Ramadan. So from all of this data, should we put all the sulfonylureas in the same basket? And my clear answer is no. I have very clear data that tells me that gliclazide MR is a very good drug for people with diabetes in general, and indeed quite safe during the month of Ramadan for the vast majority of people. But we need, of course, to focus on working on those group of people who potentially could get the hypos and address all the important points. Education is key. Education reduces the risk of hypoglycemia in people with diabetes by 44%. And those who don't, it increases by 75%. And the effect is lasting for 12 months. Another important crucial point, gray is the person who has hypoglycemia out of Ramadan, and here is his or her rate of hypoglycemia during Ramadan. That is 35%. Black is the person who does not get hypos out of Ramadan, and this is the rate of hypoglycemia during Ramadan. So by this, in simple terms, if you see a patient today or tomorrow or next week, and this person gets hypoglycemia, then you need to advise them that the risk of hypoglycemia is pretty high indeed. If they don't, then the opposite is the case. The second important point that we saw in the Darwin study that we published last year, not many people have a change in dose or in timing, and it's important to do the necessary changes. This slide was shared by Professor Ines. For gliclazide MR, it's once daily. Take it at iftar. If the control is very tight, I would consider reduction by 25%. If a patient is taking twice daily sulfonylurea, normal dose at iftar, and reduce the support dose by 25 to 50%. Try to avoid the vancomycin if possible. If not, then you must reduce the dose by at least 50%. This all means that the person needs to be checking on a regular basis, and part of the important times is the late afternoon to Maghrib time. This is the time of the highest rate of hypoglycemia. Stopping the fast when a person feels a hypo is really important. We saw in 2 studies that people do not. I have highlighted to you earlier this study as well, done recently in Saudi Arabia and Dammam. Lastly, the importance of the timing and the resistance of breaking the fast. It is clear from the study that the closer the timing of the hypo to iftar time, the more resistance of people to break the fast. And they need to be explained and educated that even if it's a half an hour in hypoglycemia could make the person end up from mild to more severe hypoglycemia. But I would like to remind you that to reduce the rate of hypoglycemia, not only you need to have suhoor, but you need to have suhoor that lasts. Less carbs and more protein and fat. So beans, full, eggs, cheese, fruits, vegetables, dairy products are all very important. What the person needs to cut up on is the bread and the rice and the potatoes, of course. So in summary, I would like to confirm that pre-Ramadan assessment is vital. During this time, we will assess the risk of the person, provide them with the necessary education, and give them a specific plan that suits them. Safety during the month of Ramadan is important, and we need to support our patients with this. Sulfonylureas cannot all be regarded as the same drug. Some of them, like glibenclamide, have much higher rates of hypoglycemia. I've shared with you today the data of the latest study published in Diabetes Research and Clinical Practice for gliclazide MR, and this confirms that low rates of any hypoglycemia with no severe hypoglycemia while maintaining good glycemic control. Finally, I would like to invite you all to the excellent website of DAR, as well as the two applications that we have, DAR Academy, as well as DAR Safa. The DAR Academy is for healthcare professionals, and the DAR Safa is for patients, with multiple programs for patient care, as well as plenty of videos from experts, including religious experts. And the last is, if you wish to get to do a short module on diabetes and Ramadan, done by the International Diabetes Federation, 15 minutes multiplied by 4 sections, you would then get an IDF certificate of completion, as well as a certificate from the European Union for medical specialists. And with this, I finish. وتقبل الله منا ومنكم صالح الأعمال. Thank you all. Sure, okay, no problem. ما فيش أسئلة. خلاص ممكن أنا أسأل إيناس سؤالين وهي تسألني سؤالين كأني في أسئلة جت.
مهم قوي. هما يمكن دكاترة ما عرفوش مكان الشات فين.
Thank you very much for everyone for listening. Professor Ines, you have explained clearly the importance of the link of hyperglycemia and comorbidities. I would like you to, in simple words, حتى لو بالعربي, to stress upon these two important points for the risk of fasting during the next few days of the hyperglycemia and the comorbidities.
في groups of risk واضحة والجروبس اوف ريسك دي عشان برضو الناس تبقى عارفة هي ما اتعملتش من غير studies ومن غير advisors وناس كتير قوي قعدت عشان تقول مين اللي فيه خطورة على صيامه ومين اللي ما لا يوجد خطورة على صيامه. طبعا احنا نحب ان الناس اللي تقدر على الصيام كلها انها تصوم، ولكن احنا عندنا فتاوى واضحة جدا. عندنا فتوى دار الإفتاء لدايابيتس رمضان ألاينس، عندنا فتوى دار الإفتاء أيضا مكتوبة وحضراتكم شفتوها من دار الإفتاء، بتقول إن الله لا يحب أن تلقوا بأنفسكم إلى التهلكة. ويعني ده موجود في سورة النساء، سورة البقرة. الدايابيتس is related to impaired immunity، دي حاجة مؤكدة، وبالذات الناس اللي سكرها مش مظبوط. لكن أنا لو عندي حد دايابيتك الجلايسيميك كنترول بتاعه كويس جدا، hemoglobin A1C بتاعه controlled، بياخد medication safe medications with fasting، ما عندوش ال contra indications اللي موجودة أو ال comorbidities اللي موجودة أو ال situations ال personal situations اللي موجودة في ال very high risk وال high risk patients، يبقى طبعا احنا بنشجعه على الصيام ونقدر نساعده. حضراتكم اكيد المرضى بتوعكم بيرجعوا لكم في الاوقات دي علشان تقولوا لهم الادفايس اذا كانوا يصوموا او ما يصوموش. بنقول حاجه للمريض اللي هو يعني مستحرم عدم الصيام، بنقول له ان هناك شخص فقير منتظر هذه الوجبه اللي حضرتك هتديها له، فبالتالي يعني هو ده امر ربنا، وامر ربنا اولى بالاتباع. مش عارفه ده راي دكتور محمد ايه، لان برضو اكيد الدكاتره يحبوا يسمعوا راي حضرتك واضح كده وباللغه العربيه وبناء على الفتاوى والاحكام.
اشكرك دكتوره ايناس. احنا فعلا النقطه دي نقطه حساسه جدا، ودي تبحثنا فيها مع عدد ضخم من الخبراء في بلاد كتير من ضمنها طبعا مصر. يمكن الصدفه الكويسه ان احنا الحمد لله مش بنقول اي حاجه خارج نطاق الفتوى اللي طالعه. الشخص اللي عنده سكر مرتفع او الشخص اللي عنده امراض اخرى زي امراض الكلى او امراض القلب او لا قدر الله التهاب في قرحه في القدم، دول كلهم على درجه خطوره عاليه للصيام بشكل عام. انما السنه دي الخطوره الاكبر ان لا قدر الله هذا الشخص لو خد الفيروس ممكن تكون فرصته ان يكون الالتهاب اللي يجي من الفيروس يكون التهاب شديد. وعشان كده احنا بنشدد وبنقول زمان يمكن السنوات اللي فاتت كان في ناس كتيره يكون سكرها مرتفع، عنده شويه ضعف في الكلى او امراض قلب وبيمشي حاله وبيصوم. السنه دي الوضع يختلف، فمن فضلكم اذا كان اللي بيسمعنا عنده سكري هو نفسه او رساله موجهه لمرضى السكر، لا تلقوا انفسكم الى التهلكه.
عندي سؤال بقى لحضرتك بالنسبه للداي رمضان ستادي. هي غيرت مفهومنا شويه ناحيه السلفونيليوريا، فبرضو محتاجه من حضرتك conclusion للداي رمضان ستادي. هل رمضان السنه دي مختلف عن السنوات اللي فاتت في ال choice of treatment or not?
Absolutely. I think the study has confirmed to us what many of us believed and saw in other studies. In so many studies, we were seeing that glycoside as a molecule, and we were not sure this is glycoside short-acting or long-acting, have lower rates of hypoglycemia compared to other sulfonylureas. And in fact, in some of the studies, including one of the studies I did myself, a randomized control study versus a DP4 inhibitor, we did not see a difference. But the question was always lingering. Is the MR better or not? Now we have clear evidence that the glycoside MR molecule is a very good and safe drug to be given to our people with diabetes, including during the month of Ramadan. If I were to be cautious, I would be cautious with the person who's tightly controlled. I will reduce the dose. The person who is maybe on triple therapy or more, and the person who is not eating suhoor. Suhoor sunnah, and delaying the suhoor is important. Some people prefer to sleep and not to wake up for suhoor. If I'm a diabetic person and taking sulfonylurea, it's important to avoid prolonging the duration of siyam, of fasting. So clearly in my mind, the study not only gave confidence for Ramadan using glycoside MR, but throughout their life, because the rates of hypoglycemia out of Ramadan was even lower and lower, 0.2%.
في سؤال جه على الشات دكتور محمد. If the patient takes one bedtime insulin with metformin, how I adjust those in Ramadan. مرة bedtime أكيد المرة البedtime دي هتبقى basal insulin وmetformin.
Okay, so we have two things here: the basal insulin and the metformin. If the basal insulin is glargine or detamir or MPH, they should take the basal insulin at iftar time, at maghrib time, before food or after food, doesn't really matter. Don't be scared, because the insulin will take time to exert its effect, so the person will not get an immediate hypo. That's one. Second, reduce the dose of the insulin by 25% at the beginning of Ramadan. Give your patient a simple algorithm, how to adjust the dose, so that if they are lower than the target, they reduce the dose. Higher than the target, they can increase the dose. What about metformin? Well, if it's the extended release, they can take it once a day at iftar. If they take the metformin 2-3 times a day, split the dose between iftar and suhoor in the fashion that the doctor prefers.
ده كان آخر سؤال.
I think the presentation was very clear, Dr. Ines. You have covered so many important points, and it's a good sign that we don't have many questions. It probably reflects clarity.
أنا طبعا بشكر حضرتك جدا، وسعيدة إن احنا بنتقابل في يعني ظروف استثنائية، وبسيب حضرتك تنهي الانترفيو الفيرتشوال ميتنج.
فين الزرار ده؟ ده Okay, so I'd just like to stress what's just been said by our admin team. I would like to finish the presentation by thanking Professor Ines Shaltoud for her very clear presentation. And I would like to thank Servier, the sponsors for today's webinar, and also thank ICOM for their work. You will be able to claim a certificate for continuous medical education by clicking the button on the bottom of the screen. I'm sure you can see it, and if you do so, it says claim certificate, and if you do so, you will be able, inshallah, to get the certificate within less than 30 minutes. So you couldn't ask for a faster service. With this, I wish you all happy Ramadan. Ramadan في مصر بكرة إن شاء الله. كل عام وأنتم بخير، وإن شاء الله يبقى العيد في ظروف أفضل من بداية رمضان.
كل سنة وأنتم طيبين.
كل سنة وأنتم